Hello everyone, I'm Rahul. I'm the director at Purnima Group and co-founder of Purnima University, Jaipur. It is my distinct privilege to welcome you all on the webinar which is on the World Heart Day, and we are grateful to all the panelists who are joining us from all parts of the world. And I'm also thankful to Anil sir for giving us this opportunity to host this galaxy of intellectuals. And I don't remember what number of webinar this is, but we all utilize this COVID time to gain more knowledge. And I learned a lot. I've attended almost all the webinars, though I'm not from the medical background, but it's a great experience overall. So Purnima University was started in year 2012, and we are a group of engineering institutions in Jaipur, and we started public health just 2 years back when I met Anil sir in Jodhpur with my father and my younger brother, who runs a hospital in Jodhpur. So we decided that we should bring up some public health courses in Jaipur also. And since our roots are from Jodhpur, so Jaipur was a bigger destination, and since Purnima University is present over here, so we introduced bachelor's, master's, and PhD courses in public health. And this is the first school at Purnima University which is having international students as well from Afghanistan and African countries. So I welcome you all, and I would look forward to all your uh, your your speeches and your takes on the World Health Day. And over to you, Anil sir, for taking the webinar forward.
Thank you, Rahul. Thank you very much. I would go back to Kandarp because he has some rules and policies to share with us, and then I think we'll go in that sequence. Is that okay, Kandarp?
Definitely, sir. Hello, everyone. Welcome to the webinar. And I'll be talking about the chat section and the Q&A section. So all the attendees and the panelists, on the bottom of your screen, you will be able to see a Q&A section where the attendees can address the panelists and ask questions, ask relevant questions to them. And to the panelist, they can simply answer it live, or they can type it in the Q&A section itself. Okay, so that is how we do things. That is how it proceeds. And if you are answering it live, you will have a particular time, 2 to 3 minutes for there. Who's giving a talk, like John sir, who's giving a talk. So he'll get time to answer those questions also, whatever questions. And I'll be referring the questions in the Q&A section to the referred panelist. Okay, so moving forward, now I'll introduce Anil sir. Today, Anil ji is here in capacity and of founder and CEO of JSPH. He has over 25 years of experience in global public health, establishing HIV/AIDS programs in Asia Pacific, Africa, Europe, North, South America, which includes training, capacity building, clinical research, testing, and counseling at centers of excellence. Anil has worked at Harvard Medical School, MIT, Brigham and Women's Hospital, Massachusetts General Hospital in various capacities, from student researcher to principal investigator. In India, he led the FXB International as CEO while managing the AIDS programs in many countries and heading US FXB as the executive director. He established over 40 AIDS programs in India. He held appointments at the University of Washington, and through its medical and schools of public health, he ran the HIV fellowship program in Chennai at Government Hospital of Thoracic Medicine in Tambaram. He was then recruited by the US Department of Health and Human Services as the Global Public Health Officer for Africa and West Indies. He sits on various boards of public health, IVF, stem cell, and technology. He had established AIDS in India, China at the World Economic Forum as an advisor. He has won various prestigious grants, including ones from Bill and Melinda Gates Foundation, World AIDS Foundation, Soros Foundation, Tata Trusts, and others. More than 100 studies, presentations, panels, abstracts, and manuscripts go to his credit. He was trained at the Northeastern University, Harvard University, and the Medical College of Ohio. So over to you, Anil sir.
Thank you so much, Kandarp. It's a great privilege to be here on the World Heart Day. It's a very important day. And in these unprecedented times, I think we all need to take care of our heart, actually. I'll give a little introduction about JSPH and Jodhpur School of Public Health. Uh, as a student in Boston area, to learn public health, we always traveled to Africa or India or Asia to get field experience. And I always wondered why India does not have schools of public health with a population of 1.3 billion. And originally being from India, of Indian descent, I always kind of was wondering why. In year 1999-2000, I had funding from Bill and Melinda Gates Foundation for migrant health care workers. We were driving with my former boss, Countess Albina, and we discussed that why no schools of public health in India? Only one school in Calcutta, which is the All India School of Hygiene and Tropical Medicine. So she said, why don't we start? So we started putting $15,000 a year aside for exploring. And then unfortunately we split and it did not work out. And finally, Dr. Arvind Mathur was on this panel and I decided around 1:30 in the morning at his HIV clinic, he used to see patients until 1:30 or 2 in the morning, that let's start with a tuition-based institute. So we started with 2 or 3 students. And today we have conferred around more than I would say 500 MPH degrees. And going forward, we need to expand more and more. And to be very clear, we are not a university. We are an academic supporting body. We work with the universities. We establish schools of public health. We recruit students. We recruit faculty. We design syllabus. We bring faculties from all around the world. Initially, most of the faculty came from the United States and England. And even from my US federal government Department of Health and Human Services, where they were allowed to come on sabbatical. But now we have trained so many people. We have so many good schools of public health in India. So we do not bring that many faculty. But again, in these unprecedented times, it's a great opportunity that we are able to run courses virtually. And we have global faculty. I think on our list, we have more than 100 faculty members. So it's a great privilege to be here. And as I said earlier, that we've got all these busy cardiologists who are donating their time today to discuss about how to take care of your heart. And I need to make some announcements, and I'm required to do for my organization. And some people sitting here, they need to be very clear. So, and it's our policy, I would say. We are not funded by any pharmaceutical company, alcohol company, drug company. We are not funded by any tobacco company, and we do not involve any child labor. And most of us and all of us, I guess, are in our personal capacity, whether we are from the government or from the United Nations. And it's very important that I make these statements because some of these colleagues on the panel are required to present this to their organizations. So thank you everybody for being here. And I would take the opportunity to start introducing the moderators, rapporteurs, and panelists, and then we will jump into the main program. So I'll start with Rahul. Rahul, a very good friend and a young, dynamic person who has founded the Purnima University along with his father. He and his father both are architects. Mayank, his younger brother, runs the Medipulse Hospital in Jodhpur. And it's been a great journey with Rahul for more than 18 months. And we have done tremendous work in public health area. We're competing for some grants, partnerships, and he's an architect. So we're even in the COVID-19 times, we're even looking into designing some labs, some buildings using the architecture and how you can maintain physical distance, the ventilation. And very soon we might be hosting a webinar on that. So we're going to use his architectural skills. And Rahul, thank you so much for having us. And I know it's a very busy time for you, but this has been great actually working with you. Dr. Arvind Mathur, one of the co-moderators today, he has been the principal of Medical College of Jodhpur, Dr. Hassan Medical College. He has over 45 years of experience in teaching, education, and research. He has worked in Saudi Arabia, in India, in the capacity of Dean Principal, Indian Council of Medical Research, various governments, including the government of Rajasthan. He ran a fantastic HIV/AIDS program. He's an expert in geriatrics, and he comes with tremendous educational background health experience, and he's a person who's like 24/7, and we're very fortunate to have him. Uh, I would next introduce to Dr. Rohit Mathur. Dr. Rohit Mathur is on faculty as an associate professor at Dr. Esselstyn Medical College, and he's a very, I would say, popular cardiologist in Jodhpur that would hear from the general population, and he has more than 50 publications to his credit. He has hosted quite a few national and international conferences. He has presented papers in Beijing, in India, at various conferences, and his interest is in research and advancing cardiology and helping the most difficult to reach population. Jagdish, who's our reporter today, very close friend, and we have worked together for last 20 years. We started to work in the AIDS pandemic. He ran HIV/AIDS program in Mongolia and India, and he also was the editor for HIV Atlas. He was trained in Russia as a medical doctor. He runs a major technology company in New Delhi called Mobiloid. And IndicChain, what you see on the screen, is one of the subsidiary or one of the bodies of Mobiloid, and it's more into academics. And Mobiloid is more a technology company. Mobiloid is based in Delhi, Boston, Singapore, and various other countries, and focuses mostly health, but we do all sort of technological aspects. I sit on its board. Geriatric is a major interest, and so is cardiology and artificial intelligence. Narayan Prasad, he's in my area. He is at the Brigham and Women's Hospital with a joint appointment at the Harvard Medical School. He has been a fantastic supporter of JSPH in these webinars. And he also runs a public health literacy organization, which is more and more focusing on educating the global citizens on public health, which is a very important topic. And Latin America is a major focus. Thank you, Narayana, for coming. I know you had a very busy day, but you are so grateful and so thankful we are to you that you showed up. Thank you so much. Now I would go to our panelists, and I know everybody has been waiting to hear from John, and John is a fantastic person. He's full of life, and he would be discussing with us his story. And so I will not go into more detail about John, but I will just say some few important words. And I think his story or his presentation will give us all the details. John is a health care executive. He has worked in HIV/AIDS area. He is right now the president and chief CEO of the board of directors of T2 Biosystems. The focus is mostly sepsis. And I am so honored that John is here today. And we are very fortunate to have him. It's a second life he's leading. And I will stop here, to go further because John will tell us the story. Thank you, John. Thanks for being here, and we are very, very fortunate. Next, I would go to, let's see what Bhupesh does. I'll go with the pictures now. Ashish. Ashish is our head of the department at Purnima University and JSPH in Jaipur. By training, he's a dental surgeon, and he also is trained in healthcare management, and he comes with more than 5 years of experience, and he's doing a wonderful job. He's a new recruit, and he has been working with us for the last 6 months. Thanks for having you. I'm sorry. So thank you, Ashish, for being on the panel.
Thanks.
Bhavna. Bhavna Sati and I have worked together for the last 20 years. And again, we started to work in the AIDS pandemic back in the year 2000. And she is a clinical nutritionist by training. She is the head of the department at the Jodhpur School of Public Health in Jodhpur and Maulana Azad University. She does a lot of clinical work, and she's a fantastic public health promoter. And she has uplifted our department to skyrocketing heights. And we are so proud to have you, Bhavna, and we are looking forward to your presentation. I love the slide I saw on fork and knife. Thank you, Bhavna. Dr. Surendra Devda. Sorry, I think fine. I think I can go randomly. That's fine. Dr. Devra is on faculty at All India Institute of Medical Sciences in Jodhpur, and he has been on our webinars earlier, and he would be discussing more today on the uh, current pandemic, COVID-19, what cardiologists have to do, how they're taking care, and how it's affecting their clinical duties, and how much they have to work harder or make their alterations in their work to take care of cardiac patients. And we are looking forward to this today, Dr. Devra. Jennifer. Jennifer is the Senior Vice President for Cardiovascular Health at Resolve to Save Lives. It's an initiative of Vital Signs, Vital Strategies. She's a physician with a focus on improving access to the uptake of effective health products and models. She is experienced physician in infectious diseases and public health. She did her MPH at Johns Hopkins, and she attended medical school at University of Pennsylvania. Currently, she's based in Geneva, and she works with our very close friend, Tom Frieden. And we are looking forward to hearing from Jennifer about the ischemic heart disease, which is probably the #1 cause of death in India among heart disease patients. Thank you for being here, Geneva. I know it's afternoon in Geneva, but it's great to have you. Dr. Jitendra Makkar. It's an honor to have Dr. Makkar here. First of all, I'm really thankful. I'm so happy he's here. And if I may say so with his permission, he has just recovered from COVID-19, and we're so fortunate to have him here. And he's really brave that he started to go back to work yesterday, and here he is on this webinar. And he would be discussing about a little bit of COVID-19 aspects, and also how it has played role a little bit in his life, and how he's taking care of his patients. Thank you, Dr. Makkar. And I think it was very important to bring Dr. Makkar here because we are in Jaipur, and it's the first time we have a physician who is joining us from Jaipur. Thank you, Dr. Makkar. Dr. Nene. Dr. Sriram Nene is a cardiovascular and thoracic surgeon. He is a gifted person who was raised in United Kingdom. Who was born in United Kingdom and was raised in the United States. It'll be very interesting to hear what I say about him. So I think everybody needs to be attentive. And I know everybody has been wondering who he is, what is his relation to Bollywood actress Madhuri Dixit. But interestingly, I have to say that I didn't know until I spoke to his PR officer that his relation. So he's also a very popular surgeon. So to start with, Dr. Nene was born in London, grew up in the US, and now he resides in Mumbai, very close to the place where I used to live when I was living in Mumbai, Dr. Nene in Andheri near Chandan Cinema. And he attended Washington University in St. Louis, Missouri in the Scholars Program. It's a very, very competitive program. It was a combined undergrad and medical school program. After obtaining his MD, he trained in general surgery at University of California, Los Angeles, where he also did a vascular research fellowship and published and presented in peer-reviewed conferences and journals. He finished his cardiovascular and thoracic fellowship at the University of Florida. He practiced as a partner in Denver, Colorado as a board-certified cardiothoracic and general surgeon, specializing in open heart coronary and valve surgery, minimally invasive and robotic surgery, and endovascular and open aortic surgery. He's a fellow of the American College of Surgeons and a member of Society of Thoracic Surgeons. In 2011, he moved to India to scale up medicine using media, technology, and smart services marketplaces to improve access to evidence-based international global standards. Along the way, he has been a seed investor and chief medical officer at the wellness startup Goki. Hope I pronounced it right. With his better half, which you all know, Mrs. Madhuri Dixit Nene has also created an edutech called Dance with Madhuri, fantastic, and a film company that sold its first film to Netflix in 2018. Congratulations, Mrs. Madhuri Dixit and Dr. Nene. He's now focused on scaling healthcare to the planet using a combination of approaches. we're so honored to have you, Dr. Nene, and I hope we can take this forward. And it's been very interesting talking to you and your PR office for last few days. And we hope we will take this forward and how we can bring cardiovascular health and public health more and more, and also surgery. I don't think I have missed anybody, but I definitely want to thank my colleagues, Jaideep Singh, who's taking care of the office while we all are here, Praveen and Rakesh, and also very thankful to Bhupesh and Kandarp, who are running the show for us. Without them and Praful, we would have been nowhere. So it's been a great, great honor. And looks like our friend Rati Godrej has joined us from Bombay. Rati is a very good friend and very supportive of JSPH. Sri Ram, Rati was also trained at UCLA. She did a medical school at University of California, Los Angeles. And now she's in Mumbai, worked at the American Consulate in Mumbai. She sits on the Harvard India Health Center Executive Board. Also she's the Executive Board of Public Health Foundation of India. She's unwell, but she really wanted to come and say hi to everybody, or at least be part of this panel. So Rati, it's so nice to have you, and hope you feel better and get better. And I would now hand over to Jagdish to introduce IndiGChain, and from there you could give it to the moderators. It's very important we spell out and discuss what IndiGChain does.
Thank you, Anil. It's great to be here. Thank you, Anil.
Thank you, Rati.
Great to be here and to have such an amazing panel here discussing this important topic. Thank you for bringing everyone together.
Thanks, Rati.
Looking forward to it. Thank you.
Hope you feel better.
Thank you so much. Thank you. That's very kind. Thank you.
Thank you. Good evening, everybody, and good afternoon. Thanks, Anil. IndiGChain is the digital skills partner to JSPH and is an offshoot of Mobiloid Group of companies. We are at the situation where we are trying to create the world's largest pool. We are trying to create the world's largest pool of digital skills, and including the medical professionals. So it's a lot about digital health, which comes to wearables, the telemedicine, and all those things, and including the mHealth technologies that we have all in India and abroad. And I'll just hand it over to Dr. Arvind Mathur to take it forward. The moderator, please.
Thank you very much. I would first thank Dr. Anil for having organized such a wonderful set of panelists for this important panel on World Heart Day. And our first speaker is John, who is an example of the development in the modern science and the human willpower. And I request him to narrate his story. John, it is for you to tell us about your experience, please.
Thank you very much. Anil, thank you for asking me to join. And to the panelists and those that might be listening in, thank you for all that you do, especially during the current pandemic. It's really appreciated. So I'm going to share a story with you that was described in the world's most prestigious peer-reviewed medical journal, the New England Journal of Medicine. It's a story about courage in the face of adversity. And I'll tell you this story today on World Heart Day with gratitude and honor of my heart donor, and also to raise awareness about heart disease and the importance of organ donation. In 2017, I faced the greatest challenge of my life. I was the CEO of a diagnostic company doing exactly what I love to do, which is advancing life-saving technologies. I had been on an extended trip to Malaysia, where we had just bought a company, as well as Mexico and Brazil, where we were working with local governments. I, in fact, returned just in time to hop on another flight, this time to Aruba, for a much needed week of vacation. It was actually April 16th, 2017, Easter Sunday, when we arrived in Aruba. For those of you that aren't familiar with it, it's a small island in the southern Caribbean Sea, just off the coast of Venezuela. We arrived after a day of travel, exercise, and an early dinner, went to sleep at about 9 o'clock. My girlfriend woke up at about 2:30 in the morning, thankfully, and found me unconscious and unresponsive. I was taken to the local hospital in Aruba, defibrillated, stabilized, and finally airlifted to a hospital in Miami, Florida. My vacation lasted officially less than 12 hours. I spent the next 10 days at the hospital in Miami, undergoing test after test, showing signs of heart failure, including a crashing ejection fraction. I code blued once, and unfortunately after 10 days had no diagnosis. While I was working each day from my hospital bed, I was also pushing for a transfer to a hospital in Boston, Massachusetts. And concerned that I was at risk of sudden cardiac death, the doctors finally agreed to release me under two conditions. One, that I agreed to wear a life vest, which is a wearable heart rate monitor / defibrillator made by Zoll Medical. And two, that I agreed to travel directly to the hospital in Boston, Massachusetts. I will tell you as an aside, I fulfilled the first obligation. I didn't exactly fulfill the second one, in that I first traveled to New York to run a shareholder meeting, a board of director meeting, and a quarterly earnings call. But then I went directly to Boston. So fast forward to my admission at Massachusetts General Hospital. On day one, I had my first surgery to implant an ICD. Those of you who are familiar with it, a pacemaker, to control my arrhythmia. On day two, another surgery, this time to implant an Impella device into my left ventricle to improve blood flow. And on day three, another procedure, this time to obtain a heart tissue biopsy. On day four, we finally had a diagnosis, and I will never forget those three words: giant cell myocarditis. It's a rare and deadly disorder. It was first described in the literature in 1905. Giant cell myocarditis has been diagnosed less than 300 times in medical history, most of those during autopsy, and it has a mean time from diagnosis to death of a few months. My doctor described it as a grave diagnosis and said that I would be in the fight of my life. As a CEO, I have to process information very quickly and make decisions. And quite frankly, I really leaned on those skills. Every time the doctors or nurses left my room, I opened my iPad and read everything I could get my eyes on about giant cell myocarditis. Unfortunately, there's not that much in the literature. And so when the doctors re-entered my room, I asked them to describe the game plan. My doctor said I needed a heart transplant, and I had been added to the heart transplant list, and that I would undergo another surgery that day, this time to be placed on life support, or in fact, veno-arterial ECMO. As this audience knows, VA ECMO patients are typically sedated into what you could describe as a medically induced coma and connected to devices that take over the function of both the heart and lungs. It's considered a rescue or a salvage therapy, and it carries significant risk, including a high rate of death, vital organ injury, and irreversible brain damage. In United States football terms, it would be described as a last-second Hail Mary pass to try to win a game. But in this case, it was to try to save my life. Now, I had never been sick a day in my life. I was an athlete in college. I don't drink, I don't smoke, I don't use drugs. I have no family history of cardiovascular disease. I've trained my entire life, and I'm about to be put on life support. This is the definition of adversity. And I was going to need every single ounce of grit that I could find. So I asked the doctors a question. Rather than being put into a coma, can I stay awake when I'm on life support? And I remember the responses being something like, John, that's not typically what's done. Or, John, that would be a horrific experience. But that wasn't what I was asking. I was asking technically, medically, could it be done? Could I stay awake while I was on ECMO? Because I had already decided if it was possible, that's what I was going to do. Going back to what the doctor said earlier, I was going to be in the fight of my life. And if I'm going to be in the fight of my life, I'm not about to take a nap. I'm not about to be put to sleep. I'm going to stay awake. I'm going to be my own best advocate, and I'm going to fight. And that's exactly what I did. So I woke up from surgery, and I'm now on life support. The breathing tube had been pulled. I'm laying on my back. I can't really move.
21 hours.
I look down and see tubes coming out of my torso. I'm on a constant blood transfusion. I immediately realized what the doctors meant by horrific experience, both physically and mentally. However, I was awake. I was engaged. I could communicate with the doctors and nurses, but make no mistake, I was fighting for my life. I spent the next 8 days on life support before undergoing another surgery. This time a sternotomy was performed and mechanical devices were placed in the left and right side of my heart, a BiVAD, or if you will, a left ventricular assist device and a right ventricular assist device. For those familiar with these devices, an LVAD can be portable. Many heart transplant patients that are on the waiting list end up getting an LVAD and can go back to work and resume a somewhat normal life. An RVAD, on the other hand, I am now in the hospital and I'm leaving one of two ways, with a terrible outcome or with the blessing of a donor heart and a great outcome. This would be the last bridge to a heart transplant, which hopefully would come in time to save my life. So I was officially on a medical leave of absence from my company, but I continued to work every day in the hospital, speaking with my leadership team and our board of directors. In fact, I somewhat jokingly say now, my girlfriend would go outside of my room and put sticky notes on the outside of the door in the cardiac surgical intensive care unit that would say things like, please do not disturb, John's on a conference call. You can imagine how that went over in the intensive care unit. And I wasn't trying to be Superman. I was really trying to stay sharp and stay focused. After all, I was the CEO of a public company. I had made commitments to shareholders. And sure, I was in an ICU bed, but I could still lead. And I frankly believe the will to live is a real thing. I saw it firsthand. The next 45 days were anything but smooth. I battled hospital-acquired pneumonia. My lower legs turned black. I risked amputation. I developed a large, life-threatening clot in my chest. I had to come, frankly, with the terms of the reality that I might not make it in time for a donor heart. And I also had to wrap my head around the fact that for me to survive, another family, another person had to experience a terrible tragedy. And that was one of the most difficult things that I had to go through in the hospital. A few days before my transplant, I asked my nurse the same question that I had asked her every single day of my hospital stay. How are we doing? And her response was different that day. She said, I'm worried, John. I'm very worried. I knew exactly what she meant. There was a very real chance that I wouldn't survive long enough for a donor heart. But I told her the same thing that I told everyone in the hospital. I never give up. On July 8th, 2017, I received a life-saving heart transplant. And on that day, I set a new goal to officially return as CEO by October 2nd, the start of our fourth quarter. There were obstacles. I got an infection while I was still in the hospital, Pseudomonas aeruginosa, which, as you may know, is a multi-drug resistant gram-negative bacterial infection that can lead to sepsis and many times death. I had no feeling in my lower legs. I suffered critical illness neuropathy. I was told it might take months in a rehabilitation hospital to learn how to walk again. 29 days later, I walked out of that rehab hospital. Well, technically they wheeled me to the front door to follow protocol, and then I walked to the car. And I officially resumed as CEO as planned on October 2nd, 2017. I'll end this story by sharing two things that I'm currently working on. First, I'm writing a book on my experience, including the story of dealing with extreme adversity, as well as powerful lessons in leadership, strength, and the will to succeed. And second, I became CEO of a new company in January, T2 Biosystems, as Anil said. We have the only FDA-cleared products able to detect sepsis-causing pathogens directly from whole blood in 3 to 5 hours, without the need to wait days for a positive blood culture. And so this is a case where what has been my passion for 30 years has become my purpose: to advance life-saving technologies and fundamentally transform the way we deal with patients who are at risk of sepsis. So thank you for letting me share my story. And again, thank you for all you're doing to advance life-saving technologies and improve patient outcomes.
Thank you, John.
Thank you, John. Thank you very much. So we take a lot from your study, to be lively, to keep the will of living alive, and to fight with all the audacities is what I suppose you have done. And I not only congratulate you, but I take a lot from you. I understand that you had a very, rare disease, but now what we are facing these days is the most common disease of, ischemic heart disease. And I don't see any ways where you could have escaped this disease, because this was not in your hand. But if we talk of ischemic heart disease, let me ask Jennifer to you. Jennifer, the ischemic heart disease is quite common in Southeastern Asia and particularly in India. So what do you think are the ways where people can, escape or avoid, or at the best, if they are diagnosed, they can care themselves? What are your takes?
Great. Well, first, I just wanted to thank Anil and the rest of the conveners for inviting Resolve to Save Lives to speak today. So at Resolve, we think that we can save 100 million lives globally over the next 30 years by preventing cardiovascular disease by intervening really in 3 key areas. One is by increasing the global control of hypertension from 14 to 50%. Second is by reducing global dietary sodium intake by 30%. And finally, by eliminating artificial trans fats in our food supply. So let me just first talk about trans fats. So in India, it's actually estimated that nearly 1 in 20 deaths from cardiovascular disease is due to the intake of artificial trans fats in foods. Trans fats have no nutritional value and are not needed by humans. The WHO has set a target for elimination of artificial trans fats in the global food supply by 2023, and we're making great progress. India is soon expected to pass regulation that will limit the amount of trans fats in oils and fats by 2% to 2% by 2022. And there's additional legislation pending that will limit trans fats in food to 2%. But it's really critical that these pieces of legislation make it past that final finish line and are actually implemented. Let me quickly talk about sodium. So sodium consumption is another critical factor in India and leads to both cardiovascular mortality and also kidney disease. Recent data showed that on average, people in India eat about 11 grams of salt each day, which is more than twice what the WHO recommends for intake. But there are actually proven strategies that can help us reduce sodium intake and that are tailored in ways to which people actually take in salt. So for example, if most of the salt is coming from home use, bold media campaigns and even low sodium salt and other low sodium condiments can help people reduce their sodium intake. And then finally, policy measures like limits on sodium in packaged food or front of package labels that include warning signs that warn consumers about high salt foods can actually been proven to decrease sodium intake. And so these are really impactful, scalable tools that India can implement now to ensure healthy populations into the future. And finally, globally, we have to talk about better control of hypertension. So, you know, as you mentioned, John had undergone an incredible ordeal and thankfully came through it on the other side. But many people have hypertension, face ischemic cardiovascular disease or heart failure because of this hypertension and don't make it through, yet this is preventable. But what we see right now is a very leaky cascade of care for hypertension from diagnosis to control. And what we wind up with globally and in India is less than 14% of those with hypertension actually have it under good control. But there are examples of very strong programs that are improving these numbers. So in India, there's an initiative called the India Hypertension Control Initiative, which is led by the Ministry of Health and Family Welfare, the Indian Council of Medical Research, state governments, and the WHO Country Office for India. And they're using very simple algorithmic protocols for treatment, and they're bringing hypertension care closer to patients to overcome barriers that result in poor retention of care. So I really think there are very proven methods that can help us to combat ischemic heart disease in India and globally.
Jennifer, thank you for highlighting these important issues related with these important cardiovascular diseases or so. What do you think are the evidence gaps which we need to address for preventive measures or so?
So I think you were asking about the evidence gaps. It went muted for just a minute. Gaps. Okay, great. So in general, we know about some of these interventions that I mentioned work well, but I think there's a lot we can do to actually optimize the impact. So for instance, in India, I talked about front of package labeling for salts and other high sugar foods and other, harmful nutrients. But we really need to build the evidence to see which type and design of front of pack labeling will have the most influence over consumer behaviors in India to have the greatest reduction in purchase of food with high levels of salt. And I would say we also can use operational research and quality improvement interventions to rapidly test and document how to improve things like retention and care for hypertension treatment while we are actually doing the programming. So we don't need to wait to build the evidence and make the perfect program. We can actually build the evidence while we're also bringing care to patients and expanding care. So for instance, while we have very effective medicines to treat most people's hypertension, we really need to better define the models of care that will be most patient and pocketbook friendly and lead to greatest long-term control.
Jennifer, what about the cost of these, and how do we make these sustainable?
Yeah, I think that's an excellent question. It's on all of our minds. So I think we have to look at both the health system / government perspective as well as the patient perspective. So from the health system perspective, many of the interventions I've discussed, particularly those that are focused on nutrition policy, are best buys in public health and actually have significant return on investment. So they actually save money because they prevent hospitalization and costs from catastrophic illness. In addition, we can design chronic care models for hypertension that are more rational from the public health system to sustain. So for instance, recent data has demonstrated that a combination of spacing out visits for hypertension care for stable patients and task shifting to less trained cadres or less specialized cadres such as nurses or even in some cases community health workers can actually help India achieve nationwide hypertension treatment without additional health workforce. And then finally, we definitely have to think about what the patients are paying out of pocket. So hypertension, we know, negatively impacts the socioeconomic status of affected individuals and families. Hypertension and other non-communicable diseases actually follow patients who have poor access to nutritious food, poor access to clean air, and inadequate health care. So the policies we're calling for really help to level the playing field by enabling a healthy environment for all, from the food that patients eat to the health care that they receive. And adequate access to healthcare can actually minimize the cost to the patients by moving towards a person-centered care model that reduces the burden on patients in terms of travel costs and lost wages by spacing out appointments and bringing care closer to home.
Thank you, Jennifer, for highlighting these important things, which are the facts are known, but the problem is in execution of those things and bringing them to the people. That is the most important task. And I think this Government of India has also taken up under their program for non-communicable diseases to have this strategy going down to the grassroots level with the health and wellness centers, which are being planned over here also. Thank you very much.
Thank
and
you.
Now I'll request Sriram, Dr. Sriram, to mention to us the obstacles which we face in cardiac care in India or globally. The things which you had also just mentioned during your introduction, that in India we have many obstacles for executing these cardiac care models or so. We'd like to listen from you.
So Neil and Arvind, thank you for having me on the panel. It's great meeting all of you. John, a very inspiring story. And believe me, I've done my share of heart transplants in my career, and the type of impact you have on someone's life directly is phenomenal, but to hear it from the other side is always very, very important to understand. So thank you for that. So Arvind, I think in 2011, I was operating at breakneck speed. And what I realized is 300 to 500 cases a year was probably the most I could do. And when I looked at the planet, there's 7 billion people who require care. And in order to scale them, what we said is, let's adopt an approach where we take media, technology, and smart services marketplaces, combine them, and in doing that, raise awareness and access. So let's go back to the problem. Why we moved to India was that in India, you have about 1.6 to 1.8 million doctors taking care of about 1.35 billion patients. And that's divided with 30% of those in the metro areas and 70% in the rural areas. Of those, only 1 million are allopathic docs, and only 2% of those go to the rural areas. So you have a huge mismatch between patient to doctor ratios as well as patient to bed ratios. When you look at that, how do you change what happens? Because much of what we see in India is a natural history study. And to be honest with you, we're moving from an agrarian to an industrialized society where by 2023, it's estimated that most people will die from acquired diseases. And even now, heart disease is #1, not just in India, but globally. And when you look at this in perspective to the current situation of COVID, we've had 1 million people die of COVID. Well, 18 million people a year die of COVID worldwide. I'm sorry, of coronary disease worldwide and heart disease and strokes and whatnot. In India, that's no different. And it does not discriminate, right? And so what we believe is that in order to have most impact, we need to, #1, raise the awareness of the public. How we do that is by creating entertaining and educational pieces, and we have a film company which does that. At the same time, we have a technology company which basically brings together a EMR with AI on blockchain in the cloud, which can basically take information in any language, interpret it, give you a differential diagnosis, and scale a doctor's reach. Because the truth is, no matter how hard you work as a physician, there's no way to cover all your patients, and particularly in the rural areas, it's impossible. And then the third part of it is bringing together a very sophisticated smart services network where we can triage the patients and get them to the care they need. And so in my estimation, look, we cannot take care of all the acute problems effectively. In the US, we would talk about door to balloon time and a measurement of heart muscle, which you lose. In India, it's more like rickshaw to door and then door to cath lab. And I mean, whether you're in Mumbai, where the bed ratios are fairly sufficient in parts of it, or you're in the rural areas, it's very, very hard. And I would say a lot of that is from denial and rejection. A lot of it's from lack of awareness. And then the second part of it is lack of resources in the way of institutions, doctors, and other things to take care of it. So our goal then is to use a combination of approaches. The most interesting part of this is that in COVID, we've learned a lot. And globally, what I've seen and what I've talked to multiple colleagues in the field here and abroad, that the number of inpatient admissions and people going to the hospital with chest pain, chest pressure radiating to their arms, shortness of breath, or in the case of women and others where you don't have the systems, indigestion or other things, has gone down significantly. And as a result, in India, the last thing which I'll say is that we don't have an all-cause mortality monitor at all. And so the WHO and the World Bank figures on all-cause mortality are estimated. We don't know how many people are dying of heart disease, or for that matter, COVID. And that to some degree is true globally. So the difficulty then is figuring out which resources to use where. But I would say, as the old saying goes, an ounce of prevention is worth a pound of cure. And that if we can move the pendulum from acute care to prevention, early recognition, and early treatment, we will significantly improve outcomes because we'll deal with patients much sooner. And in doing that, the center of the universe has to be our patient always. Whatever you do as a physician, you took an oath. And that was to, above all else, do no harm. But at the same time, it was to do immense good. And everyone on this panel knows that, and they adhere to it, and they're doing some fantastic work. But I think the bottom line is, how do you scale us? And that's what we're trying to do. Telemedicine is one way. There's a few other things which we're employing. Some of the things which I've done in my career is learned a lot in creating edutechs, film companies, this and that. And I think it has to be a cross-disciplinary approach where we look at it from different eyes and try to bring them all together. And it's going to be films, people from industry, people from medicine, people from education, all coming together as one to improve the healthcare equation globally as well as in India.
So I understand, Shriram, that the problem is immense, and better utilization of resources, more awareness. I think these are the clues which you have given us. But do you think there are, you can propose few more things to reduce the suffering of cardiovascular disease in India, and for that purpose, maybe all over the world?
Sure. And so it's a great question. You know, there are obvious risk factors for disease, right? But to me and you, that's obvious. If you're struggling to survive, as parts of India are, right? Many parts of India, how are you going to get past that from an educational standpoint and from an awareness standpoint? You know, Jennifer talked about, you know, nutritional and diet oriented things for hypertension and things like that. I think that's excellent. But I think that we need to act often and early to intervene, to raise awareness on the risk factors for disease. Secondly, to talk about the symptoms and signs, and then to create networks where we can triage patients who have to come in for care. If you have a family history, if you have other things, that's the only way I can see that we can utilize our resources best and intervene before people come in. And, you know, for me as a heart surgeon, it was often intervening after the person had an event. And the frustration was I could fix them. I could bypass their coronaries. I could fix their aorta. I could do all kinds of things, but I couldn't turn back the clock. And the frustration was that even as good as you were, if they were left with a low EF or if they were left with permanent damage, they became a huge issue for themselves and their families. And so I think in what we're proposing and what we're building, and it's a wide, holistic, end-to-end, cradle-to-grave kind of approach where you intervene early and often. I do see a huge impact in changing things. And it's a matter of bringing together the best people on one playground and an ecosystem and having them operate and build things which will come together very fluidly.
So I think Shriram has picked up a very important point of utilizing our resources in a better way. And I thank to you for being instrumental and, you know, picking up media as creating awareness. Let us now move to our next panelist, and Dr. Jitendra Singh Makkar, you have just recovered from COVID. So just wanted to ask you that, do you think that regular care for NCDs is suffering at time of COVID? I mean, these are the days when we had most of our beds filled with COVID patients, most of our, you know, manpower getting dedicated to COVID care. So do you think that these non-communicable diseases, maybe ischemic heart disease or CVS, like these things have suffered in COVID era?
Yeah, Rohit, that's what is concerning me. In the initial period of lockdown, there was a real fear in the mind of on the part of physicians also to address to the regular issues of non-communicable diseases, hypertension, diabetes of their patients. And actually, patients suffered a lot. And, as we are involved in the acute care also, people were presenting 2-3 days after they had MI at home, and by the time they came, the severe LV dysfunction had already set in. So that is the concern, and that concern is going on. People are still afraid of going to their doctors, but now the things with time have improved. There are a lot of telemedicine involved. Video consultations have started, and people have resumed going back to their regular consultation with their physician in their clinic and in their hospitals. And hospitals are also learning with time that how to address the needs of their regular patients other than COVID, their non-COVID patients. But this issue has to be addressed in a bigger way because this epidemic is not going to settle down at least in another 6 months, 1 year, whatever time. No expert is able to tell. But as I was reading in the Lancet on 26th on the editorial that this is a syndemic kind of situation where this COVID is interacting with the non-communicable diseases, and there the synergistic action of both is what is bothering us, and we cannot consider them just as a comorbidities, but they're actual problems, and they're parallel epidemics going on of, you can say, diabetes and heart disease and the virus, COVID virus in India. So that is the horrible situation, and we have to more focus on the non-communicable diseases to fight with, even with COVID. Because those patients who are keeping good health, even at the age of 80s, I have seen them recovering very well. But those who are careless about their regular comorbidities, they are suffering the COVID more. So that's what I want to stress on.
Dr. Jitendra, thank you for narrating this, and we are thankful that you have also come out of the trouble. Now, for a regular patient care, are our hospitals ready with this, or are the hospitals safe enough for patients to visit? Or can we segregate the infectious from contagious patients from the others or so?
Yeah. So since there are a lot of people maybe watching our discussion, those who are not doctors and population at large, so this message has to be spread that yes, the healthcare facilities are learning how to deal with the situation, and I think this will be a long-lasting positive impact of this epidemic. That we are learning how to separate at least the respiratory disease patients, because I remember last few years, we admit a patient of pneumonia. It is among other patients of ICU. And at 4th day of his admission, we come to know that this is H1N1 positive, and then we isolate and move our all resources. So that is a deadly situation. By that time, the damage had already been done. So similar thing is can happen in the future for COVID also, because this is going to stay, this virus or other virus. So I think now the segregation is important right from the door of the hospital. I think a separate flu clinic, most of the good hospitals have made a separate flu clinic where the screening is being done. Then we have to admit these respiratory medicine. We have seen neuro ICUs, we have seen coronary ICUs, but maybe we have to now make respiratory ICUs and keep these respiratory infection patients separate till they are diagnosed what they are. And there should be a kind of barrier nursing or whatever epidemiology you can apply to these patients. So that is a learning which healthcare facilities have to do, implement that and sustain that over time, because this is not a short lasting thing, and there can be more viruses coming on the way. So probably this is the practice we have to start now. And our hospital, we have definitely started this practice right from the door of the hospital. There are separate queues for this ILI-like illness, and then there are separate, triaging, and there are separate admissions for.
Yeah, I think there is a need for confidence building among the public also for this.
Yes, definitely. So this is my very clear message to all the people who are listening to us, that if they are suffering from any such disease, it is more, dangerous to be at home and suffer with COVID rather than to, go to your clinician, get your regular care done. And then even if you suffer COVID, you will suffer less.
I think there is a need, as has been mentioned by Dr. Sriram also, of involving the smart technologies to triage the patients so as to minimize their encounter with the hospital itself also. I think that has been great on Dr. Jitendra. Now I'll request Dr. Surinder to tell us that he is in the major institute, main institute of this region of Jodhpur, All India Institute of Medical Sciences, Jodhpur, where they have been having both the burden of the non-COVID patients and the COVID patients. So how are they managing this in the institute? I'll request Dr. Surinder to tell us about that.
First of all, thank you, Anil sir, who has again invited me to the webinar. And the enthusiasm which I saw in Anil sir was fabulous. It was in the last webinar also, I saw the same type of, he was so enthusiastic, so active in this conducting these webinars. So I'm thankful to you, sir, and again inviting me for this webinar. So we at the All India Institute of Medical Sciences, Jodhpur, definitely all physicians in India, we are facing the burden of both this chronic cardiovascular disease as well as COVID-19. Now, India is already facing, it is an epidemic of CV disease also, and over this now we are facing COVID-19. So since beginning of the pandemic, the institute has, the policy was very clear to segregate the patient as much as early as possible. So we had a triage in the OPD area also, we have a triage in the emergency area also. So as soon as the patient, the first landing of the patient, if it is in the OPD or in the emergency, first patient has to go through the COVID screening test, which has been given by the Department of Family Health and Family Welfare by Government of India. Now, once the patient clears that screening area, then the patient is again go to either emergency department where the initial treatment is given to the patient, or the patient will go towards the true clinic and in a different types of ICUs which we have made, different categories of ICU depending on the severity of the symptoms. So another important, since the start of the pandemic initial, when the lockdown was there for a month, everything was shut down. Then just after the lockdown, we have started using the telemedicine, and we are using it fantastically in most of the patients, because the chronic disease patients, we are most of the time we are able to manage through telemedicine facility, which has been there in the institute. And the people are also gradually there, although initially we had a difficulty in convincing them for the telemedicine facility, but gradually they are also understanding that going to the hospital only to get continuation of their medications, they are also now, they are accepting, when we are around 6 to 8 months of this COVID-19 pandemic. So they are also now comfortable with telemedicines, and almost we are having a full slots of around 1.5 months of telemedicine. So that telemedicine tool, we have used it fantastically in this pandemic. Another important initiative which the institute has taken, they have trained all of their staffs, junior residents, senior residents, faculties in managing suspected COVID patients. He may be positive, he may not be positive. Each and every person in the institute has been trained, on doffing, to take all precautionary measures, to how to use sanitization, how to see a patient initially, only the important investigations. There are protocols, there are versions of the protocols gradually the institute is releasing. So that is how systematically and gradually we have adapted to this pandemic, and our patients who are following in the institute, they have also adapted.
So I think this is very important, Surinder, that protocol, making some protocol and then following them rigorously is very important. And have you seen any change in the pattern of emergencies, particularly cardiac emergencies coming to you or your institute these days? And how do you, if yes, how do you manage these change in pattern of emergencies?
Yeah, Dr. Rohit, we initially see what happened when there was a lockdown, because all public transport was shut down. There was a drastic decline in the patients who were landing in our institute. Now, I cannot say whether acute coronary syndrome totally it went off, but definitely these patients might be landing into some other nearby hospitals wherever they are getting the earliest medical facility. So in our institute, yes, during the lockdown period, we had a drastic decline of the number of patients who were attending the emergency department. But gradually, what we have observed in the last 3 to 4 months, even after the opening of the lockdown, patients are still having some hesitancy in reaching to the emergencies. And most of these acute coronary syndrome patients who are landing in the emergencies, they have more complications. If you look at the acute MIs, their ejection fraction is less. They are landing with some of the complications like complete heart block. They are cardiogenic shock. So, this type of number of patients, although have decreased, but the number of complications have increased, which is definitely a great burden.
So I fully agree with you, Surendra. Although making people aware to this disease is the need of time, but with this awareness, this is where there is a very thin line between making them aware and scaring them. There are many patients who are so scared of coming to hospital that they land up in trouble. Like as you and Shriram said, they are having low ejection fraction and all cause of all sort of those problems. So we thank you, Surendra, for your participation. I now move on to Bhavna. Bhavna, why is nutrition important for a healthy heart?
Yes, Dr. Rohit, thank you so much. I would like to share my presentation in this regard. So if you allow me, I am just presenting it. I hope my slides are visible. I hope my slides are visible.
Yeah, they are.
Yeah, okay. Just a minute. I'm coming to the first slide. Yes. This is actually the kind of thing I would like to present. First of all, in my slide and left side, there is one GIF published by CDC in 2016. It is trying to tell the messages that since 1999 till 2016, that the green color is actually showing this CHD, cardiac deaths due to heart diseases. So now we can see that till 2012, we did really good, but after 2012, the number is now increasing. The data is up to 2016. Now, as Dr. Makkar mentioned about the synergy of COVID and cardiac diseases, so these are actually some of the alarming messages. This side, this another right-hand side, there is one famous photo of this clinical profile of these two professionals, Dr. Yagnik and his colleague from UK, Dr. Yudnik. So here one message is important, that in spite of having same kind of BMI, the body fat percentage was more in this Dr. Yagnik, means who was representing the Asian population. So the important message is that Asians are having, are more vulnerable. They are carrying some kind of genetic memory. So behind this, with that message, actually, I would like to tell that nutrition, actually one of the preventive nutrition specifically, is one of the important factor as far as controllable risk procedure is concerned. So with the help of this, we can maintain proper height. I need not to tell all these details, maintain cholesterol levels, blood glucose, or pressure, or with the help of this physical activity, and use of or exposure to tobacco products. When we minimize it, definitely that's going to help us. And this right side of my PPT, that is actually one table trying to tell you that yes, preventive nutrition matters, and this is actually the kind of cost in hospitalization reviewed after some nutrition intervention. Now, some of the slides, because vast topic, so I'm just, this is actually some of the PPTs which are trying, this is summary of evidences which are showing association of food and nutrients with CVD risk factors. Let's take this row number 1, which is talking about carbohydrate. There are various scientific evidences which are showing that low GI food is actually improving the CVD risk factors. And definitely we have to promote or encourage low GI food in the diet. Next row, next part is this high intake of sweetened beverages. That's a problem this side in India now, Pepsi and everything, these are there. So just message from this row that comes that avoid such kind of beverages. And there are some kind of detoxifying fluid or water is there, so that is also helpful, which are going to provide you some of the vitamins or potassium in that water and helpful and even boosters, means immunity boosters too. In couple of last years, one more message actually coming in the scientific journals about sulfur containing amino acids. These acids which are available in animal foods, they are saying that they are contributing in cardiometabolic risk. So message, better to avoid it. And plant means better to have plant protein. And yesterday only ICMR has published RDAs for Indian population. They have also reduced as far as protein requirement per day is concerned. And secondly, they have also changed the distribution in a sense that initially we used to tell 60% of animal food, 20 or 40% of plant, but they have now reduced to and managed equal level. Soluble fiber, I am not explaining details into that, but in my clinical practice, I am prescribing half teaspoon of psyllium husk with half glass of water just before 3 measured meals. So that's helping a lot as far as sugar maintenance is concerned and CVD control. Nuts and oil seeds, my recommendation is that yes, 60 gram per day, but not necessarily that we should opt almond or walnut. Locally available oil seeds are also equally good. So that is a kind of message should be there with our patients. I am prescribing flaxseed, 1 teaspoon after meals. So that is also helping to control sugars. That's my prescription. Dairy products, not too much of evidence in that, but low-fat dairy product as per our RDA should be prescribed for magnesium and our calcium, which is helpful as far as cardiac heart is concerned. Sodium, potassium, Jennifer and talked a lot about it. I'm not going into that, but message was very clear from our side. But next point, actually, this is a new latest study published in American Clinical Nutrition. This is a Journal of Clinical Nutrition in May 2020, that there is a kind of impact in high temperature or dry heat basically cooked. There are now a trend that we are opting dry fryers. Like we say that these are healthier one, but actually what is happening, these are producing these NFCs, neoformed contaminants, particularly AGEs, that is advanced glycation and products, and these are really connected to cardiac metabolic risk. So again, we have to prefer the conventional cooking method, which is actually important. This is a very closing message from this site. A half teaspoon salt per day, already talked about, but cholesterol, the same status as per the RDAs. So SFAs basically has to be limited up to less than 7% per day saturated fats, and sugar limitation is required. But repeatedly from different channels, ADA, AHA, etc., the message is coming that is eat more colors. Take at least 5 colors in your diet on daily basis. So this is a bit, and why? So there are certain phytonutrients or nutraceuticals which are really helping. So these are some tables. Actually, these are prescribed range too. At the same time, what are those? Actually, for example, alfalfa. It is also known as ashwagandha here. So 20 gram per day, helping other. There are multiple studies here. B complex list is there. I'm not going to go into details. CoQ10 really helping, and there are many studies which are promoting it. 50 to 100 milligram per day, it's helping, and with statin, very good as far as side effect is concerned. And omega-6, omega-3 fatty acids from fish or milk or cholesterol or and oil seeds also is good. Multiple studies. Garlic, 4 to 10 gram garlic per day, and we have to be careful with patients who are taking aspirin. Approximately 4 to 5 or 6 butts of garlic is really very good. It's using in other treatment ailment too. And next is soya bean. I'm not going to go into details because there are multiple clinical trials in that, but 25 to 50 gram per day is actually advocated. But patient with breast cancer history or family history, they should not take, because that promotes this breast cancer probability. Now there is one meta analysis of approximately six studies, and one was the cross-section studies. They have also shown that the phytophenol present in chocolates is also helpful as far as risk reduction in CVD, approximately 37%, and 29% reduction in stroke also. So that is also can be given, but the dose was really high for that. When it is dark chocolate, that is going to help. But not only chocolate, there are other some kind of tea or even rapeseed also. They have such kind of this special phytophenol known as proanthocyanidin. Resveratrol, for many things, this is the pink or dark color of any fruit or food items. Even beetroot, very good. Red wine, beetroot, pomegranate, these are some of the sources. More than 50 clinical trials who are supporting resveratrol. Thankfully, I could see some of the scientific publication as far as curcumin is concerned. Curcumin nowadays, with this COVID events, because this is considered as immune booster or anti-inflammatory agent, and using in Ayurvedic system. But right now there are some clinical researches, double-blind placebo-controlled trials, which are saying that they are helping as far as heart disease concerned. So COVID with cardiac diseases definitely can be taken. Prescribed dose must be 1/4 teaspoon 3 times a day. So messages from all these PPTs that do not dig your grave with your own knife and fork. We have to be careful and eat well, and very important message, and definitely some of the restriction is important, so that should be followed.
Thank you, Dr. Bhavna, for again highlighting the importance of nutrition as related to healthy heart. As was mentioned by Jennifer also, I think this message needs to go to the whole public, and changing the nutrition could help us in having our healthy hearts. Now, what would you advise in quickly about the preventive measures like exercise, nutrition, sleep, balanced diet during lockdown, etc.? During the lockdown period, what would be your suggestion?
As far as I know, I came to know from various physicians, clinicians, that that exercise was improved. Why? Because now people are having sufficient time, and there was a kind of improvement as far as lockdown is concerned. People have done good quality of exercise, good responses from the side of some of the physician clinicians that sugar level has been improved. That's what I came to know. But yes, we say that exercise is actually having approximately 35% risk reduction. So it's important for those who have to sustain 1,000 steps per day. That's our prescription. When it is divided into 3-4 times, that is again very good. Not necessarily should be one go. And for a patient, actually, we need to know that this prescription has to be given with very careful observation. We need to see any kind of myocardial infarction events or any kind of angina before prescribing any medication 60 days prior to that. And whenever we are prescribing any exercise regime to CVD patients, so completely tailored exercise regimen based on MHR, and then tailor it based on that, then only would be the prescription for exercise.
Thank you, Dr. Bhavna. I'll hand over to Dr. Rohit if there is any question. I think there is a question by Gaurav. Is there a requirement to include awareness on lifestyle diseases in school curriculum? I think you could take, Dr. Rohit could.
Yeah. So
tell this.
I think this is a valid point, because as Shriram has very rightly said, that awareness to disease and is very important, and this awareness has to start very early in the life. And what better than keeping it in the school curriculum, so that the kids, they come to know what healthy diet is. Now, when we talk about Indian scenario particularly, we know that in India we are facing double-edged sword. One hand, we are having poverty and undernutrition, but at the same time, prevalence of obesity is on higher side in school-going age children, because many of them are fond of fast food and all those junk foods. So I think this is the appropriate time to tell them that what's good for them and what is not. And hopefully, if they can inculcate these habits so early in life, they can maintain it for forever.
Thank you very much. So now I'll hand over to our repertoires to give us the gist of the panel discussion.
Sorry, Anil, you are on mute. I'm sorry.
Sorry. Over to you.
Okay, great. Okay, thank you. I was not planning to step over anyone's. Great. What an amazing webinar. Now I can see all the experts speaking. My apologies. I'll be calling all of you by your first name. I know culturally it could be a little sensitive. I'm going to start with John, and what a fantastic presentation, sir. I mean, what you said, being a physician, I almost feel like this is cardiology 101 or medicine 101. This should be taught in a junior residency program. Your personal journey, being healthy, athletic man, going through something called giant cell myocarditis, which has a survival rate of 3 to 5 months. Most of them are done postpartum. He kind of walked us through the entire cardiology in a complicated case, from BIVAD, ECMO, heart transplantation, complications of heart transplantation, and going to your legs, scleropathy, and how you survived it was very fascinating. And I think the key message you kind of talked to us, especially for medical professionals, in addition to speaking of teaching us basics of how disease progression could happen, you mentioned 2 P's, passion and purpose. I mean, that kind of caught my attention, that we as care providers should look closely into that. Somehow we need to integrate your philosophy about life, positivity, and resilience, and connect it to what we learn in medical schools. Fantastic job, sir. I'm going to Jennifer. Very key message. It caught my attention. I'm going to tell everyone I know in my group something you should know. Trans fat has no nutritional value, period. There's absolutely no nutritional value. Why are we still consuming it? It's a junk and contributes significantly to the hypertension. And you spoke about India and hypertension. Almost 80% of the hypertensive patients are not under control. And I like the fact that you connected hypertension to the social determinants, such as air quality and poor healthcare access, which is beyond our control. That's where policymakers, the government officials have to tie in. And that's a fantastic connection, talking more on an upstream dots, social determinants. Sriram, one key word I can think of, you brilliantly said, we have a scaling crisis. Problem in India is not the talent, it's the scalable crisis. How you connected, we only have 1.6 million doctors. Out of that is just 1 million are allopathic for 1.3 billion people. And then you talked about disparities between urban and rural. That's fantastic. If you take that one, it's kind of worse than any underdeveloped countries. If you stratify that to the rural area, just that group would be worse in the entire globe. And you talked about patient-doctor ratio and patient-bed ratio. What I liked about your statement, somehow being in both parts of the world, you are trying to use media, a very powerful tool in the Indian market, technology, which is AI, machine learning, blockchain, and connect it to smart networking services. I mean, that's outside of what we learn in medical school. We never think of media entertainment. We probably learn a lot of benzene rings, but not definitely entertainment. That's fascinating connection. Thank you for connecting that. Very good points. Scaling crisis in India. Jitendra, you kind of made me aware of we should not look at COVID and comorbidities. A lot of us, I did a presentation on COVID and comorbidities several months ago for one of the academic institutions. You made a point, it's not comorbidities, it's actually a parallel epidemic. Don't downplay the other diseases as, oh, it's a comorbidities, it's just there and they die more often. You made it look like it's a parallel epidemic. We should not connect them as interdependent. It's actually huge monsters. That's a very good connection you said. Surender, very good example of your institution, All India Institute of Medical Sciences, very well respected institution in India. How you kind of, your institution is balancing the crisis of COVID and non-COVID. You know, it's a two different elephants that India is going through. You kind of shared how you balance it. And one interesting thing you made is your institution is leveraging telemedicine. Telemedicine is where you kind of using to do something more innovative, more frugal innovation rather than disruptive innovation. Very impressive talk on that. Bhavna, what I learned, at least even though I should know this, BMI and body fat is not the same. You kind of nailed it. Because you put two, Caucasian and Indian man next to each other, look the same, and you kind of show them 9% versus 22%. Now I need to keep thinking, what is my body fat? That's a very good take on nutritional variables. You kind of narrated it, kind of highlights how cardiologists should incorporate nutritionists in their clinical practice and the preventive practice. That's it. I think I got my apologies. I've missed out anything from you guys, any messages, and I hope you or my partner will save me if I ignore any key points.
Okay, I'll take, thank you so much. I think it was a great summary, and I think you did a wonderful job. You always do, wonderful job. So thanks for, joining us. I know you have a busy schedule. You got a 12:45 appointment or grand rounds, I guess. But this was a fantastic panel. This is not the end. This is just the beginning. We will take this forward, and a report would be generated. It will be shared with everybody internally. We will publish it. And definitely, I have learned a lot. We all have learned a lot. And I'm sure the audience, and we would be sending the reports and also the copies of this webisode to everybody on the panel. And we will be in communication. And I know a couple of you are not on the WhatsApp, but we will communicate through email, and we will be in touch. So this is great. And I'm sure if we do more and more these kind of webisodes or webinar, we would definitely control the heart disease or, curb the issues with the cardiac patients. And also, I think there's a lot to learn on nutrition. I think what John said, it was a very inspiring story. It's people learn so much from these stories, and I do go and talk about my kidney transplant. And I think, John, what you've done today, you have taught us so much, which we could not have learned the other way. And I think Narayan said very clearly, you don't learn this in medical schools or cardiology fellowship, actually. So fantastic. And Sriram, I think wonderful, moving to India and what you do in technology, connecting all this blockchain, plus the entertainment. We did a lot in HIV AIDS, entertainment, all these street dances, but definitely I think there's a lot to do. And as a group, we all can do so much. And again, I'm very thankful to Jitendra, recovered from COVID-19, went to work yesterday, you are here. And the moderators were fantastic. The rapporteur is great. Jennifer, it's, I think, dinner time for you in Geneva. This has been great, actually. We learned a lot from you on ischemic heart disease. And I think we will take this forward, and you will hear from me very soon. And I will give over to Ashish to thank. And I think in India, it's dinner time, late dinner, which is another big major risk factor, I believe, for diabetes or heart disease. And lunchtime in Boston, and I think dinner time for Geneva. And over to you, Ashish.
Thank you so much, sir, for giving this opportunity. And on behalf of JSPH, Purnima University and IndicChain, I would like to express my gratitude to all of you who have come together from various places for a cooperation, and which enabled us to conduct such a highly fruitful webinar. And I wanted to say that healthcare is always changing. Sometimes changes have been driven by science, innovation, technology, but now it's economic time. And healthcare professionals are the smartest, most innovative, most conscientious people on earth. And they're seizing the opportunity to change the old ways of doing things and launching new approaches of patient care ideas, whether the things may or may not work, but need to be tried and evaluated. And we are transitioning from volume-based to value-based care approach. And my heartfelt thanks to each and everyone for the energy, innovation, and giving such a wonderful time to us. And last but not the least, I want to say that working together for the good of the patient, we cannot fail. Thank you.
Can I just make a request to all to have a group picture and just keep a memory of this webinar, and just turn on the cameras. I'll request all the members to turn on the camera and just wave your hand to make it memorable. Say cheese and goodbye to all. Goodbye.
Bye. Bye-bye.
Thank you. Bye.
Thank you, everybody. Thank you.
Thank you so much. Thank you, everyone.
Thank you so much for being there. Thank you.
Thank you.
Good meeting everyone.
Thank you.